Well, hello. My name is Bob Fryatt. I'm a member of the Faculty of Public Health in Global Health Committee, and I'm very pleased to be here moderating this webinar today. We're here to discuss a new collaboration between the Faculty of Public Health and WHO, and this is aimed at strengthening essential public health functions globally, and it follows a memorandum of understanding that was finalized last summer, and we've been doing preparatory work since then. And today we hope to give you an overview of this new initiative or new faculty, and to look at the progress and next steps. I'm very pleased to have with us today from WHO, Dr. Kassoum Diallo, who's the unit head of the Health Workforce Policies and Data Unit in the WHO Academy. Then we will hear from Lara Kontas from UK HSA about her experience implementing the roadmap in Montserrat. Then we'll hear from Mina Endley and Sarah El Kofaji, the two specialist registrars who are managing this project for the faculty. And then our last speaker is Fateh Ogunlayi, who's consultant in public health, FPH director of training, and more importantly for this webinar is a member of the FPH Africa Special Interest Group, who will be giving his reflections on how this is going to work. So with that, I think we have quite a lot to get through. The session is being recorded for future reference. And please can I ask you all to use the Q&A function rather than the chat if you have any questions. And then we will be having a session at the end where we will have questions for all these speakers. So we're planning to go through all the presentations and then have a Q&A session at the end. So please do put your questions as they arise into the Q&A function, which you'll see on your screen. So with that, here's the agenda. And we are going to start with an opening presentation from WHO, Dr. Kassoum Diallo. And so Dr. Kassoum, okay, over to you.
Thank you very much, Bob, and thanks, colleagues. A real pleasure to be here. And then I would like to extend my sincere thanks to Bob and the team for inviting us here. And it's a great opportunity also to discuss in the context of the Memorandum of Understanding that we're having with the UK Faculty of Public Health. And it's also my pleasure to talk to this audience because we speak the same language, as we used to say in my science courses. So we speak the same language. In that context, next, please. We are also together in terms of bringing the different dimensional impact on the health systems together. The health system challenges are increasing, as you know, in numbers first and in complexity. And they are facing multiple and overlapping stressors and shocks. And when you look at this slide, you realize that in reality, whatever you look, from which perspective you look, there is an impact on health system. And when you talk about impact on health system, there is an impact in priority on human resources for health. Because in each of these dimensions, the health workforce is critical. And we cannot create single systems for each of these dimensions because these stressors and shocks need to be brought together because we only have one health system per country and we only have to strengthen this health system to be able to face these challenges. So next, please. In that context, we in WHO did during COVID, can I have the next slide? In that context, we in WHO, In that context, we in WHO did a number of pulse surveys to assess the impact of COVID on health on the health systems in different countries. And we did 3 rounds of pulse survey. And in each of these rounds, health system challenges came as the main disruption source of the health system. In most of the countries, more than 2/3 of the challenges that were faced by country were health workforce related challenges. And in most of the others, you cannot exclude the impact of health workforce availability in this. Unfortunately, when people were looking at health system and trying to strengthen them, health workforce and the public health dimension will tend to be neglected. And that's why we brought together different partners to work together on strengthening the workforce that is aiming at strengthening the essential public health functions, including the emergency preparedness and response. Next, please. And what I like in this work around the roadmap is the fact that in reality, people tend to think that it's a WHO roadmap. It is not a WHO roadmap. Of course, WHO is the secretariat, but as you can see from this slide, all leading public health institutions and agencies and associations are part of this work. So, and this is a good practice. Rather than each of us developing different tools and guidance and bombarding countries with hundreds of tools and guidance, we decided to come together and come as one and develop a tool and a guidance and a mechanism through which countries can strengthen their public health and emergency workforce. In that context, we came up together as a partnership to represent the public health capacity covering all spectrum of the health, including protection, promotion, prevention, and including also the public health emergency management, rather than having a siloed approach. As we speak, we just completed last month the 5th steering committee meeting, and then we have more than 70 partners who endorse the roadmap. And these 70 partners are operating in more than 150 countries and covering more than 90% of the global population. So again, this is a good practice of partners, institutions, and associations coming together, identifying a gap and trying to solve it together rather than in silo. Next, please. And what we did first, we tried to agree on how do we define the workforce? What's the composition of the workforce that delivers essential public health functions? Of course, you have the core public health workers, like epidemiologists, field epidemiologists, etc. Those are in what we call here the group 1. There are those public health officers in ministries, but also in districts who are focusing primarily on public health tasks. And this is the central group of the public health workforce. But in addition to that, we know that this group alone is not in charge of implementing the full spectrum of the essential public health functions. As such, we also have health and care workers who in their daily work perform, in addition to clinical activities for most of them, but also a number of activities that are related to public health. And if you are the only doctor in a district or in a place, in a region, you cannot choose what to do. You have to do everything, including some of the prevention, promotion, and some others that are really not specifically clinical activities. And you have a certain share of your time that you dedicate to those activities. But in addition to those health and care workers that represent our group 2, we have also those we consider are allied occupations, like water, sanitation, hygiene, environmental health. You have air pollution officers, you have many other activities that contribute to strengthening the overall public health and the implementation of the essential public health functions. So in reality, we try to recommend moving from occupation-specific, occupation-based approach of managing the public health to a function-based approach to managing public health. What does it mean? It means in reality, in some countries, what an environmental officer does in some countries is done by another occupation in other countries. What an epidemiologist or field epidemiologist do in some countries can be done also, some of their tasks are done by some other occupations. So rather than looking at how many epidemiologists or field epidemiologists you have, look at how many people you have can perform the task or the services that have been identified in the essential public health functions. And this is how you should be planning your workforce. So it's a paradigm shift in a way that we approach all of these. Next, please. So based on this understanding, we came up with a conceptual approach of the roadmap, focusing on 3 interlinked action areas. The first, of course, is the entry point, is how you define the essential public health functions. And you know there is a global list of essential public health functions, but the list needed to be operationalized, and the group worked together with leading public health associations and institutions to come up with a list of sub-functions and services, separating the enabling services and the service delivery services. And this is really the entry point for the roadmap implementation in each country, where we try to identify what would be the priority functions and sub-functions and services at country level, and whether or not you have the right workforce to implement them. The second action area is the competency-based education. But before coming back to the competency-based education, let me go first to the third action area, which is the mapping and measurement of occupation. This means identifying and estimating the gaps with regard to your workforce availability to implement the essential public health functions and the priority services that you have identified. And from this, you are able to identify whether or not you have gaps. And from the gaps now, the action area 2, the competency-based education, is an approach that you can have to strengthen your workforce to make sure that your workforce have the competency required to deliver on those functions and services, and how you should educate through lifelong learning material and other mechanisms to give them the necessary skills and behaviors that are needed to strengthen this workforce. As such, these are the 3 action areas. It doesn't mean that there are not other activities, but these are the main entry points that you can use to strengthen your public health and emergency workforce. In that context, then you need to contextualize all of this at country level to make sure that the country context is reflected in your implementation and your prioritization. Next, please. We came up with an operational approach that has primarily 3 main steps for each of these action areas to make sure that you have workforce that is fit for purpose. The first that we call benchmarking, that might not be the right word because benchmarking may have different meanings depending on the context and the evolution of the things. But benchmarking here is to do your situation analysis to see where you are today in your public health and emergency workforce. And from this benchmarking, then you develop a roadmap or an implementation plan to strengthen and to improve your essential, your workforce. Those countries who are already at this stage, you need to go through full implementation in terms of how your countries prioritize the functions and sub-functions, how your countries implement the competency-based education, and how all of this is informed through strong data and taking into account the classification and also the function-based planning that I had described earlier. So this is the operational approach. This is a progression matrix. And of course, countries may have different other ways of monitoring and measuring their progressions, but this is something that we had recommended that have been implemented in few countries. Next, please. The roadmap team came up with tools and guidance. One thing is to develop the conceptualization, but the other thing is to develop tools and guidance for implementation at country level. For each of the action area, the tools and guidance provide you with a step-by-step approach on how to implement these and how to prioritize these and how to bring together a multi-sectoral working group at national level to be able to adopt, in most of the cases, a One Health approach to bring the different sectors together, to bring the different key stakeholders together, and to make sure that we are working together and we are not working in silo. And these tools and guidance have been tested in many countries and in many regions. And we will have the pleasure to hear today the example of Montserrat, but it has been tested in high-income countries like England, in medium-income countries like Georgia or Kenya, or in low-income countries like Uganda, for instance. These are some of the examples. It has been tested also in Latin America, in Colombia, and in many other countries. And we are currently testing it, implementing it also in 20+ countries. Next, please. I think you have to click several times for this one. The other approach that we adopted is to institutionalize the roadmap within the WHO. And you can see here there are a number of initiatives, global work agreements, but also national department-related tools and guidance that adopted the roadmap approach in terms of developing these tools and guidance. The WHO pandemic agreements that you all know include language that was extracted from the roadmap work. And in the what we call the global public program of work for the next 4 years, prioritizing the work that WHO will be implementing, the roadmap is fully reflected, but also in departmental and other initiatives within WHO, like the GHEC, the One Health. You know, there are many other initiatives, internal initiatives that are 3-level WHO initiatives that also adopted the mechanisms, the tools, the guidance, the language that has been developed by the roadmap. So we are not limiting ourselves to the conceptualization, development, tools, and guidance. We make sure that other WHO work and initiatives adopt the roadmap approach and adopt the tools and languages that have been in the roadmap. Next, please. And as you can see here, one thing is to develop those tools and guidance and institutionalize within WHO. The second thing is to make sure that countries implement it. And you have here in this list countries who have initiated or are planning to initiate it or have implemented fully or partially some of the aspect of the roadmap tools and guidance. And some of these countries also have expressed interest, are about to start. So we are in this context. What I like in this is that you see all different types of countries from all regions, and to show that there is a universality in the approach, and then most of the countries have understood the usefulness of the roadmap to strengthen their preparedness and response. And that's also something that is important because we are demonstrating that implementing this is feasible. And we do hope that this group will contribute to strengthening the implementation in different countries. Next, please. And you will ask me, those countries who have implemented the roadmap, how they use the data, and what are the key features that have been implemented. There are a few features that we can highlight here. One is, of course, the multi-sectoral governance for this. It's not only a health issue. It spans across different sectors. Many countries are assessing their current situation through a benchmarking. Countries are using the outcome of the results of the work that have been implemented, to strengthen their health system reliance, to strengthen their policy and planning, to strengthen their education using the competency-based education, or to strengthen their employment and then the regulation, or to strengthen the curriculums or the national public health institutions. These are few potential uses that we have seen, and potential uses also that countries can do to adopt this approach. So again, we are trying to be as operational as possible to make sure that one thing is to conceptualize, develop tools and guidance. The second thing is that to implement the roadmap. And the third thing is that to use the outcome of the roadmap to strengthen public health reform, public health systems, and public health work at country level. Next, please. And the next is, how can you support? You can support as partner, the UK Public Health Agency faculty, where you can support us in facilitating the implementation across the different action areas, but also you can support the development or the revision of national health workforce strategies, plan and actions, but also you can support that in resource mobilization, because there is a need to mobilize resources for implementing all of these. At the same time, as an expert, once all these, or the memorandum of understanding is operationalized and finalized, so we do believe that your expertise would be needed to help countries in the different action areas, in particular in prioritizing the essential public health functions and services, in country benchmarking, in competency-based program implementation, and etc. So there is a niche here for the collaboration that we can work together and better support the countries. Next, please. Of course, we all have different profiles. We all have different expertise and experience in different countries. But these are some potential profiles that we believe would be critical in supporting countries. Of course, the understanding of the public health workforce and the tools and the guidance working in this area, but also understanding of the tools and guidance that have been developed, but having experience in different countries, in different regions, but also given the multi-sectoral approach, being able to network and bring different stakeholders from different sectors together to work together. I think that should be the last slide. I would like to, okay, yeah. Next slide is the current program that we are adopting and the approach that we have put in place. And again, this approach is indicative. All countries who have implemented it are currently using more or less this approach, but contextualizing to national realities and national context. And in that context, that it would be important that we work together and we make sure that all partners adopt, or at least all partners follow a similar approach in supporting countries and a similar approach in working together. I think you need to click another button here. And where the partner support is required, from the capacity building to the national implementation and to use of the results of the roadmap implementation to develop national plans, strategies, and etc. So this is very important. And we do hope that we can count on the UK Faculty of Public Health to better support countries to really make sure that the implementation is going beyond 100 countries. This is our aim. And we do hope that the expertise that you have will be useful in that context. Next, please. Thank you very much. Back to you, Bob.
Kasim, thank you so much. That was an excellent overview and update. Really very helpful indeed. We're doing well for times, but we'll have questions at the end. But one thing I could just to warn you with, Kasim, it'd be great to hear how WHO is checking to make sure this is all on track? I mean, how do you know all these efforts are going to build up to when there's a next pandemic, the countries are much better prepared? It'd be good, maybe at the end you could tell us a little about what's happening in your secretariat, but also beyond, to know that we're all on track to prepare. Anyway, on to our next session. And as you heard from Kasum, there was some early uptake in a few countries across the world. And fortunately, the UK HSA was a part of that. And so we are very pleased to have with us Lara Contas from UK HSA, who's going to talk about the implementation experience in Montserrat. So Lara, over to you.
Thanks, Bob. And good morning. My name is Lara Contas. I am the Workforce Development Lead in the UK Overseas Territories Health Security Programme within UK Health Security Agency. And my team's remit is providing technical support and supporting capacity building across the 12 UK Overseas Territories. And today I'm going to give an overview of our experience in supporting Montserrat and mapping and measuring its workforce to the essential public health functions using the WHO methodology. Next slide. So just a bit of background, Montserrat is a British overseas territory located in the Caribbean. The picture that you can see on the right of your slide is Soufriere Hills, which is a volcano that became active in 1995 and resulted in half of the population migrating overseas. Currently, Montserrat has a population of less than 5,000. This means that there is quite a small workforce responsible for a wide range of roles. There's also limited case exposure, which makes it difficult to keep skills up to date, and insufficient staff make it difficult for staff to attend CPD or upskilling opportunities. There is a significant shortage in nursing. This has now extended to other staff such as medical technologists and pharmacists, and this has resulted in some burnout. Recently, adjustments have been made in salary, but they've yet to see the benefit of that. Next slide. So in addition, Montserrat has an aging population with 1 in 3 adults having a non-communicable disease, and these being the major cause of hospital admissions and death in Montserrat. Next slide. So with that background in mind, when this methodology was presented at our UK HSA, UK Overseas Territories conference for the Chief Medical Officers, Montserrat was very eager and volunteered to implement this roadmap. WHO colleagues had meetings to sensitize the key stakeholders in Montserrat, and then our team led a 2-day workshop to prioritize the essential public health functions, as it was decided to take a phased approach and to focus on 3 essential public health functions just due to the small capacity. We then mapped the occupations and validated the findings through interviews and surveys. Early insights showed that strong interconnections across roles. Montserrat now has a stronger baseline which can be used, and visible gaps to help on workforce development have been identified. Information gained throughout this process has informed standardization of training opportunities, and some of these have since now become mandatory. This is also the first time this application of the tool occurred in a small island context, so it's exciting to share some of the learnings to hopefully support some similar settings in the future. Next slide. So there are some challenges as well in using the methodology in a small island context. So individuals usually hold multiple responsibilities and job titles, so this made it difficult to clearly categorize some of the roles. Montserrat is also highly dependent on external agencies for training. So again, this made it difficult in mapping some of the workforce development. You can see some of the agencies that they work with. So of course, WHO, CARPHA, the Caribbean Public Health Agency, OECS, so the Organization of Eastern Caribbean States, and the UK Health Security Agency. Additionally, constraints of small islands were often overlooked in terms of the mapping methodology. So in small places like Montserrat, priorities can change day to day in terms of political landscape and the clinical priorities. Next slide. So some of the findings were that nurses are essential to essential public health delivery in Montserrat, often covering multiple specialties, and additionally acting as managers, educators, and policy contributors. Interviews confirmed alignment with initial mapping, with most participants having received essential public health function-related training through a mix of formal education, on-the-job learning, and through external agency support. Lack of local training capacity limits workforce development. This is especially true when it comes to succession planning and maintaining up-to-date CPD and CME, particularly challenging for doctors. Just due to the small number of doctors on the island, it was difficult for them to travel overseas for more formal training, as another doctor would then have to cover additional roles. And next slide. So on this slide here, you can see a snapshot of some of the actual mapping that we did. So the first table to the left gives an idea of the top 5 professionals on the island. The numbers have slightly changed as this was completed in 2024. And then the table below shows the percentage of time spent on the essential public health functions that we mapped at the time. The CMO was the only role dedicating 100% of time to the essential public health functions, and we looked at that job title as well. The job description was incredibly broad. The table then on the right displays the 3 essential public health functions that were prioritized by the stakeholders for mapping. So public health intelligence, health systems planning and financing, and public health workforce development. You can see we then map the occupations to the sub-functions to see where the responsibilities for the functions lay, and this was a good opportunity to look at any gaps as well. And next slide. So some of the learnings for other small islands who want to conduct this exercise: first, to engage a broad range of stakeholders early on, particularly finance and human resources. When doing this, we found that a lot of the functions were happening outside the Ministry of Health, and that those stakeholders were not aware that they were contributing to the essential public health functions. So this was a good learning, and Montserrat now will integrate stakeholders more in carrying out these functions and working together. Secondly, partnering closely with WHO for contextualization and comparability was vital. The support from Dr. Kasum and Dr. Tapas and the rest of the WHO team was incredibly helpful in categorizing the workers, as we at first found it difficult, and also wanted to ensure that it was relevant for benchmarking with other countries. And next slide. So in terms of next steps, so Montserrat will continue to collaborate with external agencies to design standardized training to ensure colleagues can carry out essential public health functions. So since then, we have conducted a population health leadership training. This was through UKHSA and the King's Fund. And Montserrat have also signed an MOU with Calderdale and Huddersfield NHS Trust for continued education. They currently have 2 fellows now in Montserrat, and an observership program has been set up for staff to come to the UK. They also have access to e-learning for health programs under NHS, so all the health workers have access to the same learning that we do here in the UK. And we plan to map the additional essential public health functions. And this, however, will be done in phases, again, just due to the local capacity and resource limitations. Lastly, these findings will eventually inform a public health workforce development strategy, and Montserrat can use this evidence for business case for new roles. Next slide. And just to say that the final report has been published on Montserrat's government website, so you can find the link here in the slides if you want to read a bit more. And if there are any questions or anyone wants to connect with Montserrat, please do feel free to send me an email. And just thanks again for inviting me to speak.
Lara, thank you so much indeed. Very, very interesting. And we'll come back to this later. It would be good to hear about UKHSA, where they're going to be involved in other countries. Maybe you can just come back to that later on. And maybe it'd be also good to hear your views about whether there's any in-service training. You mentioned how people have multiple roles, so whether they can do their development and training whilst during their work time, rather than having to leave the country. But maybe we'll come back to that at the end, if that's all right. Okay, so we are on to the next session, and when this new arrangement was set up with WHO, the faculty agreed to have a project designed to manage this sort of uploading of expertise in UK to WHO, and to map out our public health capabilities in the UK and assets in the UK. And so this project has been taken on by Mina Endley and Sarah El Kafaji, and they are now going to give us an update on where that project's got to, and any lessons coming out of it. So you can go on to the next slide. I'm going to hand over to Mina. Mina, over to you.
Morning, colleagues. Thank you, Bob. I'm Mina Endley. I'm one of the 3 registrars who's been tasked with working on the Global Health Education and Training project on behalf of the Global Health Committee. So what we hope to do today is give you an idea of the breadth of the program that we've been running. So there've been 2 main work streams. Next slide, please. One of them has been looking at effectively 2 decades of competency-based training that we've had within the faculty and lessons that we've identified over time. And the second stream is the temporary worker register for the WHO that the faculty is offering. I'll be talking about the first option with Sarah talking about the latter. Next slide, please. So this is a grossly simplified slide, but the whole idea really behind it is just to give the WHO an idea of the breadth of our faculty. The 2 main points, if you were to take 2 main points out of this, actually 3, it's grossly simplified, but it is a multidisciplinary pathway and it is inclusive. So it isn't just doctors who come in. There is a national recruitment process for multiple disciplines along with doctors that leads to a specialist registration at the end with the GMC and the UK PHR. Next slide, please. So what does our training program entail? Our training program is broadly in 4 phases. It starts off with an academic foundation, which most of you on the call will already know about. And then as a trainee, you're supported all the way through academic practice to leadership development and then becoming a consultant. And click again, please. I was trying to find an exploding head. Those represent the exams that you have to do to pass between phases. Sadly, there was no exploding head. Next slide, please. Kasum has already spoken about this, but actually there is no single entity delivering public health alone. So within our lessons, we wanted to identify from the breadth of the faculty what has worked, what hasn't, how we are developing, and what we might recommend for the WHO to use within implementing a global competency-based program. So we ran a series of interviews. We ran a series of interviews with 15 of the faculty's membership. This was a very broad spectrum. We looked at international membership, UK membership, people in roles in the UK, roles globally, practitioners as well as specialists. We wanted to understand our growth really over the last 20 years and what could be adapted for what the WHO had to offer. Now, next slide, please. I'd like us to, the analogy I like to use to demonstrate our workforce is that of an orchestra. So if you imagine with an orchestra, you need multiple soloists or multiple instruments, but effectively you need a generalist who coordinates this orchestra. For a good symphony, you will need people to train together, you will need equitable access, and you will need stewardship and leadership. And those are the governance settings that have been put in within the faculty. Next slide, please. So I already alluded to conductors and soloists. So the conductor is, in my mind, the public health specialist who's come out of training. They know the breadth of competencies because they've covered them in training. And the soloist is someone who goes into more depth within a competency area. So for instance, a CCDC or health protection expert or an epidemiologist, etc. But effectively, if there were a public health crisis, you would want there to be a generalist that can bring together all of the soloists to play their instruments for our orchestra. And next slide, please. So my orchestra is starting to look more inclusive. We have new people coming in. We have different different soloists performing, rehearsing together. And next slide, please. Other themes that came up were introducing, with strengthening the public health workforce, we needed a ladder rather than a gate. So competency-based training shouldn't be a case of, do you have this competency or not, i.e. open gate, shut gate. Rather, it should be, what competencies do you have and how can we build on it? Now, at the start, I gave a very simple description of our pathway in, but of course we have a portfolio entrance pathway, which enables individuals who have additional competencies but not on the training program to demonstrate those and join the program. So we are building that ladder rather than a gate. The faculty has over time looked at how it could design its processes for equity. So looking at differential attainment, looking at the selection processes, do they favor specific disciplines over others? And how can you balance that out? And same all the way through training. So it's those governance procedures that help you regulate the system, as well as looking at the competencies and seeing whether they still apply. So all of those reviews happen at intervals. As well, very strongly represented at the interviews were the idea that political influence should be taught rather than acquired as a soft skill. So there was recognition of the fact that public health consultants come out and often don't have the ownership of the budget, but are required to build relationships, collaborate with stakeholders and influence. And the only way you learn to do that properly is if it is built into competencies. And as well, the last piece was around protected supervised practice. And I think this was something that has been echoed in the two presentations before us. It's been an opportunity for trainees to develop practical use of these academic competencies that they've learned. In the training pathway, we have rotations through various specialties, but actually it's supervision as well to make sure that trainees aren't doing nugatory tasks, but rather they are building their competencies as they work through. And the next slide, please. So what we're saying is the theory is great. Within the faculty, we find that supervised application and an opportunity to practice in a safe space has been really useful for our competency-based training program. I think that summarizes the first half of the stream, but I will hand over next to my colleague Sarah to talk about the temporary pathway. Oh, sorry, this is my full orchestra with the kettle drums right in the back as a new addition to the orchestra. So effectively involving people who wouldn't normally participate. Thank you.
Okay, great. Thank you very much for that, Mina. Hi, everyone. I'm Sarah. I'm an ST3 in East of England and also part of the Global Health Education and Training Project. So as highlighted in Mina's presentation, the UK is a leading example of a standardized competency-based public health training. And we're therefore in a strong position that the faculty has established the collaboration with WHO that you would have heard about earlier to support the strengthening of national health systems in delivering essential public health functions. So basically, this builds on the joint work since 2022 with WHO and the global partners to develop the roadmap that you heard about earlier. And the current phase focuses on implementing WHO's 5-year vision and action plan. Next slide, please. So as you would have seen from the previous communications sent earlier, over the next 5 years, the faculty will establish a roster of technical advisors to support the WHO and its member states in implementing the action plan and country-level work plans with the aim of strengthening national capacity to deliver the public health functions. So from our side, as you would have seen, we sort of got the priority countries list from WHO, and there are 3 current key areas of focus. So first, it's identifying countries with interest. Second, documenting in-country good practice and the use of WHO tools and guidance. And third, identifying innovations in delivering essential public health functions, especially for emergency preparedness and response. Next slide, please. So some of you may have heard from me individually, or you may have seen from the faculty's website that the initial list of priority countries went out in the expressions of interest over the last couple of months, and you would have heard from me if you have sent an application to sort of like update you that we have received your application and that this would have been passed on to WHO. So as of this month, WHO is in consultations with regions, and the plan is to have a proposed selection of 2 to 4 countries which have temporary advisors. And whenever we get an update, we'll update you guys as well as soon as we hear back. And as you can imagine, this is a continuous learning process for us as well. So we'll be reviewing the process in the future for lessons learned and refinements that would sort of be considered for any future rounds or any future applications. That is everything I have to say, so thank you for listening.
Mina, Sarah, thank you so much. There's a lot in there. Maybe we'll come back to that. There's a few things I'm sure we can get to in the discussion later. So please, listeners, if you could put any questions into the Q&A function, we will come back and perhaps go into dig into a bit more detail about these early lessons about working together. And Mina, Sarah, it'd be good to hear from you also about the early lessons about how this process is developing and how it might develop into the future. So on to our next presentation, and this we're very pleased to have with us Fatai, who's in the Africa Special Interest Group. He's been aware of this. In fact, we have a little oversight group which Fatai is a part of, guiding this whole project in the faculty, but he's also a very active member in the Africa SIG, and we've asked him to reflect on how this partnership might take place and go forward. So Fatai, over to you.
Thank you very much, Bob, and a good welcome to everyone from different parts of the country and the world. So I'm Fatai Ogunlayi, and I'm a consultant in public health in Croydon, but I'm wearing the hat of Director of Training today, and also in Africa Special Interest Group as one of the lead in the steering group. Our chair of the group isn't able to join us today, Victor Joseph, and our vice chair, but I'm hopefully be able to convey some of the work that we've done in relation to some of these areas that we've been discussing today. And I guess the main thing that I'm trying to get across in this brief minute we have is the message of we're not starting from scratch. I looked through the number of people on the call today, and there's a lot of incredible colleagues that I recognize with extensive networks. I mean, I've seen Farhang, Samia, the list goes on. And so it's that message of we're not starting from scratch, and how do we build on some of the things that we've done. And so today I'll be going through the faculty's special interest groups and how they may play a role in this, and also reflecting on some of the considerations or some of the reflections, my personal reflections anyway, that I've had having worked on various elements of this work. So thanks for moving on to the next slide. And I guess the good place to pick up is the point that Kasum made right at the beginning around some of the interconnected challenges that public health has, i.e. it is global in nature. It's not confined to one national boundaries. there is a global element to some of our public health challenges. And this is reflected in, for those who have read the faculty's 5-year strategy published autumn or so last year, is reflected in that vision statement around how do we ensure we leave no one behind and deliver better health for all. Another point that Kasum made in his really helpful presentation is how critical a resilient workforce is to all of our global health agenda, be it universal health coverage, be it global health security, be it international health regulations, or even the most recent international health policy in the pandemic agreement. There's an article specifically dedicated to the importance of having a resilient workforce within this. And the faculty recognize this, and for those who can see this a bit small, in the mission statement that's underneath the vision, is that line around the role that the faculty can play in ensuring effective and sustainable public health workforce. And from that context, many of you would know that faculty is very much a membership-based organization with around 6,000 membership. What you might not necessarily be aware of is that that membership, whilst mainly based in the UK, also spans across something like 79 countries. And through those sort of extensive networks, there are active committees that are the lifeblood, that are run by the members, that are the lifeblood of how the faculty function. And the reason why I mentioned that, if we go on to the next slide, please, is because within some of those committees are what we refer to as special interest groups. Colleagues that are on this call might already be really familiar with this, but for some colleagues it might be new to this idea. But special interest groups are established by FPH members to really harness, when we talk about the 6,000 membership base, to really harness that knowledge and expertise and think about how can we use that to provide a solid platform to deliver some of the objectives that we talked about earlier on. If you go on to the next slide, please. And it's a really busy slide. I've stolen this from one of faculty's presentation, but I think it sort of gives that message of just how active those SIGs can be. So what you see in the various bubbles in the middle are committees. Each SIG is linked to a committee, a standing committee or subcommittee, and the circles orbiting around those committees are the special interest groups that are linked to each of those committees. I guess the first thing to say is, if you are not part of a SIG and you think actually there's some stuff that looks really interesting here, this is a quick plug to say it's open to members. Please go and have a look on the faculty website, but also just to give you a sense of the scale of those special interest groups. And the reason why I mentioned this is because part of what you might be thinking today is, and how do I get involved in this initiative that we've been talking about for the last 45 minutes or so? What does that look like from a faculty perspective and from your individual perspective? This is an example. This is one way of being able to do that, because a number of those special interest groups are already doing some of the things we're describing in various form already. If we go on to the next slide, please. I'm deliberately just going to pause on this slide for the Global Health Committee, because the work we've been describing, as Bob highlighted at the beginning, sits within the Global Health Committee. And with that Global Health Committee are a number of special interest groups. Some are country-based, so you've got Yemen, Sudan, India, Pakistan, and I can see some of the chairs or co-chairs of those groups on the call at the moment. Some are regional-based, so myself, I'm from the Africa SIG, but we also have a Europe SIG. I think Gulf SIG is a relatively new SIG. I could be wrong, but we'll check that. And some are topic-based. So you've got the NCD, disaster and humanitarian response, and global violence. But a common theme across all of those, if I come back to the overall vision of the Global Health Committee, is going back to that importance of having a resilient workforce. And so the vision around promoting that multidisciplinary, competency-based public health development globally, but importantly, through organized efforts of the faculty members, through yourselves who are on this call. And part of some of the key objectives within that is thinking about how do we mobilize education, professionalization, public health, workforce development across that. So I guess I'm giving us an example of there are existing platforms that we can align with as individuals or as members or as SIGs that on the work that we are already doing. So if I maybe just zone in particularly on the Africa SIG, which I'm more familiar with, if we go to the next slide, please. Thank you. So in Africa SIG, we have, and perhaps not surprising, a vision around how do we improve health and well-being of people on the continent. If there's something missing from that vision statement, the line would also then be through organized efforts of the members of the SIG. So it's not delivered by the people within the leadership group, but actually working through the membership of the group and tapping into the expertise and the knowledge base that sits therein. We've got 3 key main work plans for this year within the Africa SIG, and you will see right at the top there is something around building public health workforce, or at least contributing to strengthening, is probably how I will phrase that, contribute to strengthening public health workforce globally, particularly on the African continent. And we've done a survey of members of the SIG as to what would that look like, and there's some real recognition of giving them a platform where they can bring some of that knowledge and expertise that people have, and how we can use that to that global good. And I think this is a really good example. This work with WHO is a really good example of how we can deliver some of those. Within that, we also have works around MOU, particularly with South Africa, in terms of promoting competency-based education. I'll say a little bit more later on that, but just wanted to share the general work plan that we have within the Africa SIG in relation to this. The next slide is I feel like a bit of a fraud, because it's examples of work that we've been involved with, and it's really great. If we go to the next slide, it's really great that I can see in the chat some of the people that have really led this work. So I can see Amy, I think you're now in Uganda, but previously in Malawi. So I can see colleagues like Amy on the chat, and Samia as well, who was really key to some of the work here. But here is examples of work that the Africa SIG have been involved with. Not all that they have led or initiated, but actually there's something about how do people recognize where the expertise lies and how do we tap into that. So Malawi is a really good example that was initiated from FCDO and NHS Consortium with UK Health Security Agency, and members of the Africa SIG able to contribute in small ways or the other towards that. And the general idea behind that is how do we share, and I'll come back later on to reflecting my personal reflection on what this work means for us as individuals and what are the considerations we need to be mindful of. But how do we share our journey as part of this? How do we share our experience, but recognize that expertise is relative, and there's an important element of local expertise and contextualizing. So there's something around there, and that journey that Sarah and Mina was talking through around the multidisciplinary approach that we've taken to specialist training and competency-based education and training. In South Africa, this is one that we lead as an Africa SIG, and this work that's been in progress for a number of years, a really strong partnership, but also thinking about how do we do that two-way shared learning around, again, public health education and training. South Africa as a nation is one that has a very similar model in terms of education and training for public health specialists than that we do in the UK, but there are some important differences. And part of that conversation is understanding contextualization of, and those differences, what can we learn from each other? What are the experiences that we can share? But actually not just doing that at sort of a senior leader perspective, but bringing in the registrars and the early career professionals and shaping that sort of mutual interaction, mutual learning right from that stage, and contributing from that perspective. Another example that Africa SIG have been involved with is the International Academy of Public Health Association. I think that's what IF stands for. And again, this is not one that Africa SIG led. This is led by, I don't know whether Muna is on the call from the Global Health Committee. This is one that Muna led on behalf of the faculty within Global Health Committee. But again, that theme around training, capacity building, how do we share knowledge and experience around how we might strengthen the public health workforce? So this example is just to illustrate that in various parts of the faculty, there are existing work of this nature that are happening. There are opportunities to build on that. I know, for example, that the Pakistan SIG once expressed interest within the for the essential public health function, this work that we're discussing. So there are already avenues that we can think about, either you're connected with or you're aware of, that you can think about, actually, is there a way that our SIG, or is there a way that I can be part of a SIG who might be interested in this work? If we move on to the next slide, please. I'm keeping an eye on time. And this is my personal reflection of having worked in those various contexts, various roles. It's on the left-hand side is the benefit, that potential benefits of being involved in this. And I think is that point on whether you've gone through the public health training as a registrar, or you've gone through this in a portfolio retrospective, or you're not in public health training or consultant, but you work in the wider public health workforce that Kasum referenced earlier on. I guess the key message is we all bring our unique expertise to this, and it's all valuable. And so just thinking about how that might contribute to this. And so at an individual members level, I've got starting from the lower there is that opportunity to serve as WHO's technical advisor, which is what the call out is for. So if you haven't seen that, there is that opportunity, but there's that opportunity for professional development elements in there. And for me personally, the greatest benefit is just that exposure to diverse health systems. I mean, people know this. You don't know what you don't know until you know. So there is a real humbling element in just recognizing the different health systems that exist, and how that knowledge can transfer even back to where you're based locally. And then, of course, there are benefits for the faculty in terms of FPH leadership and building sustainable institutional partners, and there are benefits for the countries. But perhaps what I want to spend a bit more time on is some of the, again, personal reflection, considerations as we take this work forward, and as we progress this. And hopefully those who have worked in this space, this might not come as a surprise, but there is something about just recognizing that how is our work complementing, not duplicating, an existing national efforts. I don't think there's been any work that I've done within any country context that hasn't had stuff happening locally. And there's a really important to think about just how do we do that. And I suspect when Kasum answers some of the questions around timeline and others later on, might reflect on the bit of his presentation around that initial exercise, just to scope where the help, where the support is going into. So there's WHO are really good at just understanding how do we complement this. The second point is around how do we ensure that whatever efforts or whether input we do, there's a locally owned solutions. I mentioned Amy earlier on. Really great to have Amy as we were doing some work with Malawi, just to help steer some of the work that's going on, some of the expertise that sits there, and how do we make sure that all of that links, aligns, and is sustainable in relation to this. Part of that is also recognizing that there will be other partners already working with various nations and institutions that we're working with. How does all of those complement each other? How do we make sure that we bring that together? The next point, in fact, I might bring the next 2 points together around resource, time limitation, and clarity of roles, essentially managing expectations. And how do we do that? Because on one hand, we could be in there in a technical advisory capacity. We, at Samuel might remember this, we start having conversation around, are we potentially become an assessor that we might do? Do we have capacity for that? really clarifying what does that role, what is the ask, what is it that we are we're looking to do in there, and managing that expectation. And then within that as well, it's just also recognizing that competency-based education and training is one element of a health system or a health workforce. There are infrastructures that sits around that. The number of educational supervisors, if I'm using UK terminology for public health training, that may be the number of accredited training places that people might be able to gain these experiences, the number of reflecting on Lara's presentation, the number of people that may be doing multiple roles in small island nation. And in fact, Sunita, it's a really good question you had in the chat around how important is it to have the knowledge of the local context. Very is sort of what I would say, but I'll let people come back in the Q&A. Very important, because otherwise everything is devoid of that context. And then and that's linking to navigating different governance structure. The last one, and this is probably a personal thing for me, is around what does equitable partnership look like? What does ethical partnership look like? And shifting away from that sort of decolonization mindset of we know more and actually we're bringing expertise. Well, actually, are we bringing expertise, or are we bringing our experience and our perspective? And there's an element of trying to understand what does that look like, and how do we make that sustainable after this initiative is finished? That's a really quick through. I don't think I've got any more slides. I think that was a really quick whistle through. And if there's a parting message that I'm sort of giving with this is just to say that there are platforms, existing platforms that we have that we can build on. Members individually or within organizations that are working are well connected internationally and well positioned to support this work. And there isn't a prescription that you have to be a director of public health, or you have to be a consultant, or you have to be a registrar, or you have to be a public health principal. There are different expertise that you can bring onto this, and it's really worth just pausing and reflecting on what does that look like. Bob, I'm going to stop there and hand over. Thanks very much.
Fatai, that was excellent. Thank you so much indeed. And I think you've raised lots of very good points that we're going to come back to in the discussion, along with Samir, Samir from the Pakistan SIG raised similar questions in the chat. So let's come back to about the broader implications for working with WHO on this. But let's go back to some of the questions, if I may. And Kasum, if we could, there's a couple of questions which I think are coming your way. Maybe we can start with the one that I posed at the very beginning, is that how does WHO, the bigger WHO, how do you know that things are moving in the right direction, that countries are developing these capabilities, and so when the next pandemic hits, we're going to be much better prepared? But perhaps talk about that, and then I'll maybe ask about the importance of knowledge of context. How important is it to be able to do this work? But first of all, over to you, Kasum, on that.
Thank you very much, Bob. And in fact, these were tested also during the pilot phase. There are some countries who are able to implement the tools and guidance by themselves without any external support. And some others countries got support from WHO or some of the partners. I remember having traveled to Kenya, for instance, with the CDC, US CDC, to support Kenya in the mapping and measurement, for instance. So just to say that in reality, what the benchmarking means is that countries doing a situation analysis, but adapting and adopting the tools and guidance that have been developed through a multi-sectoral approach, through the multi-stakeholder governance mechanism, and through really contextualization of the essential public health functions and the implementation of the mapping and measurement to identify where they have the gaps and to implement the competency-based education. So in that context, then one of the first steps that countries have to implement is in reality to try to know where they are today, using this framework to estimate really their strengths and weaknesses and identifying where their gaps are. And this does not need external involvement, because just adopting the framework and making sure that it's based on this estimation that they can only decide whether or not they are going for benchmarking and they are going for requesting external support. So this is the first step. Now, one thing that Fatai said, and that also reflected in Lara's presentation, is the importance of contextualization. What we have tools and guidance, because we are a global program working with global institutions. We give you the big framework, overall framework, but this framework needs to be contextualized at national level. For instance, in some countries, you need to prioritize your essential public health functions and services because not all are relevant or not all are critical or not all have gaps. Maybe you are doing very well in surveillance, but you are not doing well in something else. Then maybe you might not prioritize surveillance. You might prioritize the others where you are not doing well. Just to give you an example. So contextualization of the tools and guidance is critical. The other thing that is critical is linked to the contextualization is who should be the key players that you should bring on board in this discussion. For instance, most of the countries are now progressively adopting a One Health approach, bringing together those veterinarians and others who were not part of the overall discussion before. I remember in one of the countries that we supported when we were doing the mapping and measurement, one comment someone told us is that, I wish we had done this before COVID. We would have saved a lot of time, because in reality, there are many key players that were neglected at the beginning of the work during the COVID response. It's maybe a few months later that they realize that these players are very important and they start bringing them on board in the overall response. So it is important to take this into account. So making sure that we do a proper stakeholder mapping based on the country context and the country gap assessment, and to make sure that this is and this is in fact what and I'm seeing one of the comments, the GE type of work that are doing, but adopting the overall frameworks that have been developed in the context of the roadmap. Let me stop here.
Thanks. And maybe I can put another question to you before we move on. There's a question from Amy, more about the mechanics of how this is all good, this partnership will work, particularly around the WHO temporary advisors. So how will they be deployed? Will it be short term or long term? Is it in-person or virtual support? What's the time period it might involve? What are the contractual arrangements that we've agreed to? Who will they be working with in country ministries or institutions? Could you say a little bit? I know there's a lot. I know we're still working a lot of this out, but maybe you could just say a little bit about how you envisage these WHO temporary advisors working with you.
Okay, as you said, Bob, you are still working on the details and the operationalization of the memorandum of understanding and how all of this can take shape. But the way it is anticipated is that all will be based on countries' assessment. And countries will be able to say, okay, this is what we're going to do. This is the expertise that we need. In that context, the expertise will be sought primarily at national level. So if you have a network, and the examples that the SIG example that Fatai just described, if you have a national network or national experts at national level, those could be part of the country support mechanisms that could be established. But if the country does not have specific expertise in one of these areas, and then this expertise is available in a broader network, then these could be sought through consultancies or a special advisor mechanism. But these mechanisms are to be finalized and developed. Ideally would be that, that's why I put in one of my last slides, the profile of the people that would be needed, but we need to also come up with the mechanism through which the countries will be, depending on the country interests in the country needs, that this can take different shapes. And one of them is, of course, special advisors that could take, depending on the thing, few months to a more stable advisory committees and work. So these are some of the things that needs to be further defined, but it will definitely depend on country context and country needs and how we are going to do it. What we have done in some countries is that we sent a consultant to help in the mapping and measurement, for instance. In that context, then the consultants stay with the country for 2-3 months to do the work and come up with a report that will be used for things. In other contexts, the countries themselves ask us to help them to develop requirements, and based on the requirements that have been developed, then they came up with the profile of the people that were needed, and our role was limited to that because the countries themselves did the identification of the expertise, and then they did the hiring, etc. So I cannot anticipate exactly what format it will take. It might take different type of formats, but clearly having the expertise in this group, being available to work in different ways to support countries is already a big thing for us.
Kasim, thanks so much. And may I just a little addition to that on the contracting side, just to clarify for listeners that once these WHO temporary advisors are located by WHO are chosen, then the contract would be, there would be an agreement with WHO that this person works for WHO, you cover travel expenses and insurance, but there's no consultancy fee. This is actually sort of in-kind support, no. but WHO will be providing all the logistical backup for that person.
Yeah, in that case, if this format is adopted, definitely the country office, the WHO country office working with the Ministry of Health or the relevant stakeholders will initiate the steps and then working on things. So I gave the example of consultant because we didn't have this kind of mechanism. Of course, if we have some kind of support and then the logistic needs to be covered, this is also another way of exploring this option. I gave the example of the consultancy because that was a mechanism that had been used in the past, but definitely in the context of the memorandum of understanding, we need to clarify all these aspects and how all of this will come together. Thank you.
Kasim, thanks. We have another question, I think more for Lara about Montserrat, can you say a little bit more, what about the 3 essential public health functions that you looked at in Montserrat? Just give us a little bit more detail about that.
Yeah, thanks. So the 3 that we ended up mapping fully Montserrat were public health intelligence, health systems planning and financing, and public health workforce development. During the workshop, we looked at all the essential public health functions and did an exercise where we listed out the stakeholders and individuals on island who they thought were contributing to that function. And then at the end of it, we did a prioritization exercise where we had the stakeholders rank the functions in terms of importance or in terms of the ones they wanted to focus on in the first instance. And then from there, we did a voting exercise and took the top 3.
Great, thank you so much indeed. That's very, very helpful. I think we must, maybe one other question for Kasim that's just come up before I think it would be good to have some more discussion from you, some questions that put to you, Fatai, about the broader, how do we get the broader efforts of the SIGs to help out with this process, whether it's through WHO temporary advisors or through other way of engaging. A few reflections from after hearing from others on the call. Maybe you can speak on behalf of Samir as well for the Pakistan SIG, about how can the SIGs can help out with this process beyond the WHO temporary advisors. But before I do that, Kasim, a question back back to you that's just come up. How does this link with the JEE type scoring in going to countries and looking for the priorities for strengthening, etc., etc. WHO is also involved in in the JEE and around international health regulations. So how does these two parts of WHO meet up around strengthening essential public health functions? So back to you, Kasum.
Thanks. And in the revision of the JEE process and tools, the roadmap language and the roadmap tools have been also considered. In that context, we are aligning as much as possible. Of course, these are two different mechanisms. If a country is going straight for the JEE, they can do it, but based on the gaps and based on the things, they can also implement the roadmap tools and guidance and see how better strengthen some of the aspects that the gaps are there. Depending on the scoring, if you're scoring very poor in some aspects, then you may wish to consider how the roadmap team can help in strengthening those aspects. But the JEE members, also some of the leading people in the JEE are also part of the roadmap work. So we are trying to align as much as possible. That's why I mentioned the institutionalization, to make sure that we don't have only parallel systems that do not talk to each other. We try as much as possible to work together around some of these elements. Now, of course, the objectives and then the specificities are different. But in terms of approach, we try as much as possible to align to make sure that we don't duplicate, and wherever it is possible to, if the JEE is an entry point, for instance, for the essential public health functions, then this is something that could also be used as an entry point to make sure that the roadmap language, tools, and guidance are implemented in one way. But the JEE can identify the gaps, can identify the weaknesses, and the roadmap tools and guidance can be implemented to strengthen those, and then make sure that we adopt one approach rather than separate and parallel processes.
Great, thanks very much. There's a couple of questions about the process of becoming WHO temporary advisors, and maybe Meena, Sarah, you could come in on this. Can you just clarify how there's a question about whether do you have to be can you be an FPH member, independent, or working in other sectors beyond public health? Can you just say a little bit about the current guidance about who's able to get onto this roster and who's not?
Yeah, sure. So the current call out that went out, it does specify that as long as you're a member of the faculty, then you are eligible to apply. So if you hold any kind of membership, so you can be a fellow or like an associate, for example. And we also do check that manually as well when you send that out an application.
Great, thanks so much. Meena, I was going to ask you, Meena, maybe before we move back to Fatai, about also whether you'd like to reflect a little bit around the steering group and these other things going on around the WHO steering group. It was quite a very sort of, there's a lot happening. I wonder if you might want to reflect a little bit on you and Sarah attending that steering com. You're on mute.
Sorry, I appear to be having problems with one computer, so I'm using the other. Did you want me to come in now, Bob, or after Fatai?
No, come in now. I'm going to end with Fatai because that's going to be quite a big discussion point. If you could just reflect a little bit on the steering committee, just for the listeners' point
yes.
to hear, understand.
Yes, of course. So steering committee. So Sarah and I went to the steering committee at the end of, where are we? End of March in Geneva to present the findings that we'd had based on the work that we've just spoken to you about. And from my point of view, I mean, there were several international organizations around the table. Many of those Lara has already referred to, PAHO, the World Congress of Public Health, the IAPH, and others, talking about work that they're doing in collaboration with the WHO. It also allowed everyone to reflect on successes, things that hadn't worked, and perhaps come together with ideas of how we could move this work forward. very reassuring that the themes that our membership raised were common themes around the bazaars, which just meant that we could collaboratively consider them in more detail. So I found that really helpful. And we've also been able to engage with the AA2 stream, which is the competency-based training stream, so that we can support that work going forward. Over.
Thanks very much indeed. Right, Fatai, back to you. And maybe you could speak on behalf, because Samir's made some points about the Pakistan Special Interest Group, would like to sort of get more involved. And we have many others, as you know. Could you just, after what you've heard today, speak a little bit more about, beyond even the WHO becoming a WHO temporary advisor, how the faculty special interest groups might be able to engage more on this roadmap process, given, as you say, there's so much happening already. Maybe you could just reflect a little bit more on that. Over to you.
Thanks, Bob, and it's been really useful. I've been reading through some of the questions and the comments in there, and Kusum made that point around how do we avoid parallel processes in there, and we all know sort of the whole is always greater than the sum of the parts. So just thinking about how do we collectively bring that efforts in, and I can see Samia in the chat is already putting a call. I say, can I meet with you, Fatai and Kusum, just to think about that, because I think that's a really good point about how we do this. All of the SIGs meet up every so often. I think it might be annually, whereby there's a discussion around the work plan. And one of the things that sort of jumped at me at the last time, looking back through the notes of that, is the commonalities in some of the objectives of the various SIGs. And so there is something about how do we bring those together when we're working on similar initiatives? How do we bring that in? And I wonder whether there is a role here for the Global Health Committee in terms of the education and workforce strand within the Global Health Committee. I know there was a recent survey that went out within that committee asking what is the faculty's role in terms of general education and training and some of the areas within that. So I think there's an opportunity just to think about how do we collectively collaborate when we're working on similar things. I have certainly done a roadshow of the roadmap in previous times. I've gone to the Pakistan SIG, myself and Neil, who was the previous chair of the Global Health Committee, have done a webinar before, but there's something about perhaps we can pick up with Liz within the workforce space of the Global Health Committee. How do we make sure that all of the SIGs that's working on similar agenda actually have a common platform to do that from? And I can explore this with Samia when I meet with her offline in relation to this, but I think it's a really good point that you raised, Bob, as to just bringing the efforts together so that we're all working towards this. So that would be my recommendation, is we actually take this back within the Global Health Committee and build it in within our workforce plan, and just think about how do we collectively bring the efforts of the SIGs together around this common agenda of the roadmap and the workforce development.
But I agree totally. That's great. We're into our last couple of minutes, so I'm just going to go around the remaining speakers for any sort of final words or comments. Kasim, I will end with you. So I'll start with Lara. Any closing comments?
Just to say, I think the process at Montserrat was extremely eye-opening, particularly for colleagues in Montserrat. I think having, as I said, various individuals who might not necessarily work in the Ministry of Health be in the room and have conversations and kind of have that eye-opening moment of how their role plays a key part actually in the essential public health functions and how they kind of, fit pieces in the puzzle. I think for me, those conversations and bringing those stakeholders together was really important. And I think going forward, I'm looking forward to seeing what the other essential public health functions look like and how that can then form that evidence base for Montserrat to have a stronger public health workforce.
Lara, thanks for that. Mina, over to you. Any final reflections?
No, none in addition, really. It's just been a very interesting piece of work.
Sarah.
I guess it's just to say from the temporary advisors side of things, it's just to say that I've been quite impressed with the high level of interest that we have had from lots of people. So it's great to see how much interest we have and how much potential we have, and we have to and we hope to continue having this level of interest in the future.
Absolutely, and thanks for that. So Kasim, over to you for final sort of reflections or comments.
First of all, let me reiterate my thanks to you and the entire team for inviting us. It's great to be able to exchange and also to understand also the thinking around the work that you are doing and also the organizations through the SIGs and others. So it's very important. The second thing is that we clearly and definitely will work together on how best to implement the Memorandum of Understanding through a more operational approach to things. But I just want to recommend that not limiting yourself or this group to the work around probably the Memorandum of Understanding, because we know that the implementation of the roadmap is wider than what WHO does. So WHO is one of the key players. The tools are there, available. It's a global public good, and countries are implementing it even without WHO, and countries are seeking advice from external entities, and sometimes we are not even aware. So it's important that you look at it from that perspective, and we conduct regular surveys of our partners to know what they are doing in the countries. So this is important to understand. Now we believe that the Memorandum of Understanding might impact a lot the work at country level, because we are aware of the gaps. We are aware of some of the challenges countries are facing. We are also aware of the fact that sometimes the country do not have the right expertise to help them implement all of this. So the expertise in this meeting and in this room and with all the people who are around here will be critical in this one. We need to find the best way to channel it through the countries and make sure that this is taken on board. So again, thank you very much for inviting us.
Kasim, thank you so much indeed. It's been a pleasure, and thanks to all the speakers. Just a quick final word. We do have some the faculty has some other upcoming sessions and webinars which are there in front of you. We encourage you obviously to engage in as many as possible. But for the speakers, thank you so much for your time and effort. Lots to reflect on, and totally agree with Fatai's point. We have a lot more thinking to do in the Global Health Committee, but thanks very much for your time, and we look forward to discussing more in the future. Cheerio for now.
Thank you.
Thank you.